All right, chapter 52, we're not reading the whole thing. We've got about 10 pages, page 1042 to 1053, and the chapter is looking at alterations in musculoskeletal function. We're focusing more specifically on rheumatic disorders, on joints in particular. So the big one here is osteoarthritis, OA. You might hear it called degenerative joint disease or DJD, but this is the most common type of arthritis worldwide. It can affect one of 200 or so synovial joints in the body, and there are lots and lots of factors that can contribute to OA, including damage to a joint, say you've had a bad sprain or a bone break. It can happen with just the regular old wear and tear that comes with your joints moving your body around for years. Obesity can contribute as well, just based on the extra stress placed put on a joint. Family history, hormonal influences like postmenopausal women, and the list goes on and on. The combination of predisposing factors that I just talked about, it leads to this progressive loss of articular cartilage to the point where there's not much separating the two bones anymore at that synovial joint. What happens then is that articular cartilage, remember, when we have it, it's important because it acts like a smooth weight-bearing surface, as well as it helps to kind of transmit the load of mechanical stress down the bone. So we want that articular cartilage there. What happens is these little cracks form on the surface that deepen to involve the subchondral bone, which can thicken as well. And then as the articular cartilage fully erodes or disappears, that subchondral bone that kind of looks like a polished ivory is exposed. Cartilage fragments can break off into the joints and kind of float around freely. We can see these little bony outgrowths. They're also called osteophytes. You can see them on the sides there, which can make the joints look wider actually. And as the joint begins to lose its integrity, that synovium becomes inflamed, causing the joint also to distend. I do want to point out, though, that this is different from the inflammation that we see with rheumatoid arthritis. In RA, it's more pronounced. It happens earlier on in the course of the disease process, where in osteoarthritis, that inflammation, it happens later. The synovial fluid also can leak through into the cartilage, forming little cysts. In osteoarthritis, the signs and symptoms are usually pretty localized to the affected joint. Although early on, it can feel kind of achy and be hard to tell where exactly the pain is coming from. The pain gets worse with use and better with rest at first. As the arthritis continues to destroy the joint, though, the patient actually might start to experience pain even at rest, like at night when they're trying to sleep. The patient might feel crepitus, which is this abnormal grating, popping, crunching, crackling sound. You can hear it, and it's made by bones rubbing together. When patients have been sitting for too long or they get up in the morning, they might experience stiffness that usually goes away after about 30 minutes of activity. So once they get going, they loosen up a bit. Hebertin nodes we find in the distal or the far away joints at the end of your finger, and Bouchard nodes are closer to the proximal joints, kind of in the middle of your finger. And we can see these in patients with osteoarthritis. At first, the nodes might be red, swollen, and painful, and eventually they become painless, but they are associated with limited joint mobility. And when we are looking at the joints through radiologic imaging, we can see physical abnormalities. And there is no cure for osteoarthritis, so the purpose of treatment is geared towards decreasing stress on the joint and protecting it from additional trauma. It includes things like physical rehabilitation, also known as PT, low impact exercise, range of motion therapy, pharmacological interventions, surgical measures. It's really based on the patient's symptoms and where they are during the course of the disease. Things like losing weight and participating in simple exercises can be helpful. Sometimes patients get orthotics, so they wear insoles in their shoes. There is other adaptive equipment like a walker or a cane that can help with mobility and get patients moving around. There are lots of meds out there. Many that are commonly used are the non-steroidal anti-inflammatory drugs, NSAIDs, but we do have to be careful with those because they can lead to renal toxicity or cardiovascular side effects. There are different supplements like glucosamine that people take that can be protective. Some patients get intra-articular injections right into the joint, and then surgery is oftentimes indicated once the disease process has totally destroyed the joint, and most common hip and knee replacements. So, another question. A patient has osteoarthritis. Which principle is important for the clinician to remember? Take a look at the answers, put me on pause, and see what you think. All right, so hopefully you've given your answer, but what is most important for the clinician to remember? Most important is C. This is a progressive, non-inflammatory disease of weight-bearing joints. Rheumatoid arthritis is systemic, autoimmune, that causes a highly inflammatory symmetric, so both sides of the body, peripheral arthritis. Infectious or septic arthritis is the invasion of the synovial membrane by bacteria or another pathogen, and then altered uric acid metabolism leads to the deposition of uric acid crystals in joints, causing inflammation and what we call gouty arthritis. So the answer again is C. Infectious or septic arthritis happens when infection gets into a joint, usually by the way of blood, through a penetrating injury, or from nearby infection, and causes arthritis-like symptoms. Joints that have a history of damage or injury are at a higher risk. So when the pathogen gets in, the combination of the infective agent and the body's inflammatory response, the neutrophils that hit in to gobble up the infecting organism that autolyse enzymes into the joint, actually causes damage to the synovia, the ligaments, and the cartilage. Clinical manifestations can set in and show up within a few hours only to a few days. And we do see the cardinal signs of inflammation, the redness, warmth, swelling, pain, and limited movement. The patient can spike a temp, leading to mild fever up to high fever that is usually accompanied by shaking, rigor, and chills. And then treatment includes the use of appropriate, which is why we culture, IV and then oral antibiotics for a long time, like 4 to 6 weeks. And if needed, we can go in and we can remove fluid by joint aspiration. So release some of that pressure there to minimize damage with a syringe, or go in surgically to drain in order to avoid injury. Very rarely when a joint is replaced will a person have a reaction to the prosthetic. It's like 1 to 3% of all the joint replacements that we do in the US. If it does become infected, it typically sets in within a few weeks or months of the procedure. If the infection is severe, then the new joint has to go. It can't stay, and we replace it with a spacer that's full of these little antibiotics. So you can see in the picture the little antibiotic beads that get placed, followed by IV or oral antibiotics for 6 weeks or more. The patient then can get the prosthetic replaced when the wound is clear of any bacterial growth. For more mild infections, though, the prosthetic can stay. We just do things like debridement and antibiotics. Lyme disease is a complex illness caused by Burriella burgdorferi, which is a little bacteria that's carried and transmitted by ticks. Usually the deer tick, which as you can see in the photo in the upper right are super small. That's a paper clip there for size comparison. Some people don't even know that they've been bit. We do find these ticks in North America, in Europe, and in Asia. And when a person is bit by an infected tick, it's not totally clear how that turns into Lyme's, but what we think is that the antigenic fragments of the dead or inactivated organism trigger this inflammatory response or an autoimmune response within the body. Symptoms usually come about, they appear in the summer because that's usually when a person would be exposed. And it starts as a red macule or papule that often presents as a bullseye. And we call this bullseye this urethra migrans. You can kind of see it in the picture on the left, where it's darker in the center and then it kind of spans out. It gets bigger, it gets redder, it feels warm to the touch. It's accompanied by flu-like symptoms, fever, chills, malaise, which is that general feeling of unwellness, headache, neck stiffness, myalgia. Myalgia is muscle pain, and arthralgia, which is, can you guess? Yes, joint pain. So in some people, they develop more severe symptoms like lymphadenopathy, which is swollen lymph nodes, splenomegaly, which is an enlarged spleen, hepatitis, inflammation in the liver. Remember, itis means inflammation. They can develop a non-productive cough, testicular swelling, conjunctivitis, which is an inflammation in the conjunctiva around the eye. And then a few weeks later, the patient can develop neuromuscular symptoms, pain in the joints, tendons, bursae muscles or bones, and more than 50% of people will develop arthritis. A lot of times it's the knee that gets affected. Weeks to months later, if it's still not treated, then we can see neurological symptoms like meningitis, which is inflammation in the meninge, which is kind of the covering around the brain and the spinal cord. We can see cranial neuritis, inflammation of the cranial nerves. We can see motor and sensory radiculoneuritis, which is inflammation of the roots of the spinal nerve, and chorea, which is these jerky, involuntary movements that affect the shoulders, the hips, and the face. In some cases, the heart can become involved, which causes problems like AV blocks, which you probably don't know about yet, cardiomegaly, which is an enlarged heart muscle. It's temporary, but it can be fatal. So what we do for treatment is antibiotics. And we want to get antibiotics on board right away, either orally or parentally. We also talk about prevention. So wearing insect repellent, inspecting for ticks. If you're out in areas where deer ticks live, make sure you remove them right away. And then if you do notice a bite, that you're watching for signs and symptoms. Rheumatoid arthritis, RA, is another important type of arthritis that you should know and pay attention to. It is not the same as osteoarthritis, so make sure that you're noting the differences. RA is actually an autoimmune disorder, specifically an immune-mediated inflammatory disease, where we don't know the specific cause, but it seems to be that people who have the genes for it, they're genetically susceptible, get exposed to different triggers. Maybe it's an infection, maybe it's an environmental influence like tobacco use. Anyway, it activates abnormal or altered IgG antibodies that your body doesn't recognize as its own self. This causes the body to produce something called rheumatoid factor, RF, to try to fight this unrecognizable IgG antibody. And what happens is they're fighting, they clump together, and they form these complexes, which then trigger the release of more immune cells. So macrophages, lymphocytes, they join the party. They keep the inflammation going in the joint. More specifically, they kind of focus in the synovial tissue. And if you remember, the synovium, it's located in the joints, and it's this thin, delicate lining that helps to bring nutrients to cartilage and also provides some joint lubrication. So ongoing inflammation causes edema or swelling of that synovial membrane and joint capsule. A pannus is formed, and a pannus is like a thick layer of granulation tissue which covers and then ends up invading the cartilage and eventually destroys the joint capsule and the bone. Pannus can also lead to bone cysts and fissures. Next, we have this fibrous ankylosis, which is a fibrous invasion of the pannus, and scar formation also happens, which causes the bone to atrophy, leading to this misalignment in the joint. So at this point, this is where we can start to see physical deformities present, a restriction in movement, and also having these muscles that are now atrophied, they can cause your patient to lose balance. Finally, the fibrous tissue, it starts to calcify, resulting in the joints kind of fixating or getting stuck. and this causes total immobility. Pain that's associated with movement also can restrict the use of that joint, which can lead to further joint deformities. This illustration just shows you what I just talked about, the mechanism of RA, with the bones of the hand in the background. So to recap, RA occurs when the body's immune system attacks the synovial area in the joint tissue. The affected joints become painful, inflamed, it limits movement. That inflamed synovium, that joint capsule lining, produces fibrous vascular tissue that we call pannus. So if you look at the picture, that's the purple in the picture here. And that, remember, grows to cover that whole articular cartilage. The synovial fluid, which is kind of whitish, it's in the background there in the picture, it fills with white blood cells, and that stimulates the release of enzymes which destroy the bone, which is kind of the brown in the picture, and then the cartilage, which is the blue. All that inflammation causes damage, leads to lots of clinical manifestations that really vary based on where the person is. This is a progressive disorder, so depending on where they're at in the course of the disease and which joints are affected. Do note, though, that this is one difference from OA. Rheumatoid arthritis presents bilaterally. So if my right hand is affected, so is my left, although not always at the same rate. So maybe one of my hands is worse than the other. It also affects many joints throughout the body. With all the inflammation and damage that's being caused, patients also experience more of the systemic effect. So things like a fever, just feeling unwell, having this diffuse musculoskeletal pain. And if you look at the joints, they can appear swollen, red, warm to the touch. You might also note a restriction in movement or function of the joint, which maybe, hopefully, sounds like the cardinal signs of inflammation. The patient might report some stiffness, especially after periods of immobility, so if they've been sitting for a long time or in the morning when they wake up. And unlike osteoarthritis and RA, that morning stiffness that lasted only maybe 30 minutes with OA can last over an hour before they feel like they're kind of loose again and they get that synovial fluid moving. Over time, as RA progresses, you can see joint deformities, like in the hands. You can see the picture in the upper right-hand corner, or in the feet. If the hips or the knees are affected, patients can have a really hard time with walking. And then they can develop other manifestations in other body systems too. So I'll give you a couple examples. Pericarditis, atherosclerosis, pleural effusions. Sometimes we can see on the skin these little RA nodes, little nodules that form on the skin. We can look at labs. I mentioned earlier rheumatoid factor, and about 60 to 80% of people with RA have a positive rheumatoid factor. So we look at other things like this anti-cyclic citrullinated peptide, anti-CCP. That is an auto antibody that's present in most patients with rheumatoid arthritis, so that can be helpful in diagnosis. Other labs are inflammatory markers like our SED rates, our CRP, C-reactive protein, and then we can use radiography to see the damage that's caused to the body's structure, like narrowing joint spaces, erosions, and then eventually this malalignment. There is no cure for rheumatoid arthritis, so treatment is geared towards slowing down the progression of the disease, minimizing damage, and treating the symptoms like swelling and pain. A lot of patients start with anti-inflammatories like NSAIDs, CRX2 inhibitors, and steroids. However, we have to be careful with long-term use of a lot of these meds. We know that NSAIDs can contribute to gastric ulcers, steroids can contribute to diabetes, osteoporosis, so there's some other meds, some DMARDs, disease-modifying anti-rheumatic drugs, like methotrexate that we can use earlier in stages of the disease. And then there's a newer class of drugs called biologics that are used to decrease inflammation as well as to prevent erosion of the bone. So there's currently 5 different TNF, tumor necrosis factor alpha blockers, and these include drugs such as infliximab, which is Remicade, and then some others that I'm not going to ask that you necessarily know and learn all about right now. But take a look at those. Those are, like your Humira, your Intercept, things that you see commercials for. There's also a need for patient education about the disease process, to assess for psychological adaptation, to talk about diet. Remember that weight gain puts more stress on joints. It's important to talk about exercise and range of motion, maybe even refer your patient to physical therapy, occupational therapy, and then know that surgery is available as well for joints that are just super damaged or painful. So here you can see the x-ray. It's a rear view of the pelvis of an adult woman who has an artificial hip joint replacement. It's a metal ball and socket implant that helps to form that prosthetic joint between the pelvis and then the femur or the thigh bone. SLE, or systemic lupus erythematosus, is another systemic inflammatory autoimmune disorder. This one characterized by periods of exacerbation where symptoms are present, and periods of remission where symptoms and signs are not present. Sometimes remissions can last 4 or more years. SLE can affect virtually every organ system in the body, sometimes at the same time, although different people are affected differently. And we don't know why people develop SLE. We say this a lot, don't we? But it does seem to be a mix of being genetically predisposed combined with exposure to some kind of trigger, maybe hormones or smoking. Especially since SLE seems to be a disease we see in young women, we think there is that hormonal component involved. Diagnosis is typically between ages of 15 and 40. So what happens is when this whatever trigger happens, the body can't get rid of these B cells, which leads to an excessive production of antibodies. And one significant feature of patients with SLE is their ability to produce autoantibodies against many different tissue components. They can produce autoantibodies against red blood cells, neutrophils, platelets, lymphocytes, or almost any organ or tissue in the body. This is important because that is why it can affect so many different organs and tissues. The formed antigen antibody complex goes ahead and it settles right into the basement membranes of the targeted organs and suppresses the body's normal immunity while causing damage to tissues. As I mentioned, clinical manifestations differ from person to person, and pretty much all body systems could be affected. What's common though is joint pain, especially during flare-ups as a result of that swelling. Skin manifestations are quite common, including edema, redness. Patients also can experience this rash across their face that resembles the shape of a butterfly. The skin can become very sensitive and reactive to UV rays and can develop kind of scales or plaques. Patients can experience pericarditis, pulmonary hypertension. The kidneys oftentimes become involved with glomerulonephritis, which is an inflammation in the glomeruli of the kidneys, and actually can cause renal failure eventually. Education is so important for SLE management because, it is lifelong. We don't have a cure. So we teach patients about stress management, the importance of skin care, staying out of the sun, keeping their skin moisturized. And then there are a lot of different meds as well that can be used, ranging from NSAIDs to methotrexate to immunosuppressants to biologics. Scleroderma is a type of muscular or multi-system inflammatory connective tissue disease that has complex pathogenesis. So early on, inflammation and immune cells make their way into tissue, and this affects blood vessels. It causes vasculopathy and actually injures the vessels themselves. And when vessel walls, or there's any inflammation or anything inside a vessel, it messes up the vessel walls. It causes them to thicken. And so when we're talking about the smaller vascular vessels in our body, like capillaries, which are like only a cell thick, arterioles, venules, they can eventually become blocked. And so if our vessels become blocked, blood can't get through, and any tissue that's distal to that, it becomes ischemic. Um, Large amounts of collagenous tissue get deposited then into that skin and into different internal organs, causing the tissue fibrosis. So if you break down the word, sclero means hard and derma means skin. So scleroderma, they get this hardening of the skin. And guess what? We don't know why people develop scleroderma, but once again, we suspect it's this mix of genetic predisposition and some kind of trigger. So, about 90% of patients that have scleroderma experience something called Raynaud's phenomenon, and that is where blood vessels constrict in our fingers and toes, usually. Sometimes, though, your nose, ears can be affected. So they turn white with this constriction and then blue in response to stress or cold. And then as they warm up again, they get flushed and red and painful. Polyarthritis can develop. Fingers and hands can swell up in a few weeks or months. And then in that time, the edema gets replaced by this thick, tight skin. So you can kind of see that in the picture here on the slide. That makes it really hard to move. Right? If you've ever maybe eaten too much salt and are carrying a bunch of water, you can feel in your fingers, right, that they can be kind of hard to move, and that's related to that edema and that thickening, that tightening of the skin. This is called sclerodactyly, which is that thickening. The tightening, muscle can start to atrophy due to that tight skin too. Since it's not able to move, if you don't move it, then it goes away. Or if you don't move it, you lose it, I guess, is a nicer way of saying that. Other organs can be affected as well. So a lot of GI involvement, actually where the esophagus gets affected, and patients can have trouble swallowing, or they can experience reflux as stomach contents kind of back up into the esophagus. They can experience trouble with bowels. And they can and do die when they develop pulmonary fibrosis or lung tissue that stiffens and makes it harder to breathe. It can lead to heart failure, to renal failure. So depending on what organs are affected, we use different medications. And I'm not going to have you memorize the meds listed here, but as you can see, there's different meds for different systems that are affected. But the goal for the medications is to keep the vessels open so blood can flow. They work to lower the workload of the heart so that we don't develop heart failure. They work with the GI system to suppress acid production, to prevent GERD and acid reflux, and so on. Ankylosing spondylitis is a form of arthritis that leads to pain and stiffness in the joint and in the spine. Activation of immune-mediated inflammation occurs in the sclerotic joints of the pelvis and the ligaments that help to hold up to support the spine or the vertebral column, so your vertebrae. So if what's being affected is the spine, it should make sense that there's lower back pain. And it shoots down to the legs. It causes a lot of stiffness that can be pretty severe, especially in the morning time, and it makes it hard to move around. It limits that range of motion. Usually with this, it improves with exercise, but it's not relieved by rest. Patients tend to display this outward curvature of the spine. This is kyphosis. You can see in the picture here. It's a 68-year-old man with ankylosing spondylitis, and you can see that he's got this outward curvature. What you can't see in this picture, though, is what happens is they kind of have this forward thrusting of the hips. Your book has a pretty good picture of it on page 1051. Other things we can see: swelling in the knees, diffuse swelling of individual toes. This is called dalactosis. Treatment, we want to relieve the pain, we want to bring down inflammation, and we want to strengthen posture. So we can do these things through medications and then through strengthening and stretching exercises. Reactive arthritis used to be called Reiter syndrome. It happens where inflammation of the synovium occurs in joints as a reaction to a recent infective trigger. So there's inflammation in the synovium, which is called synovitis, and that happens as a result, as a reaction to some kind of infection. So there's three things three triggers that contribute, and they include urethritis or inflammation of the urethra, usually caused by UTIs. Cervicitis, which is inflammation of the cervix, also related to UTIs. And gastroenteritis, which is inflammation in the lining of the intestine, and it leads to this acute immune response. Triggers inflammation in the joints and tendons. And what we see is oligoarthritis, which is arthritis that affects 1 to 4 joints. So it's not polyarthritis, it's oligoarthritis, which is a small amount of joints. And usually that happens about 2 to 6 weeks after this infectious episode. We can also see the swelling in the toes, the dalactosis. We can see enthesitis, which is inflammation where tendons and ligaments attach to bone. Some patients experience low back pain. And so how do we treat it? Well, we're treating inflammation with anti-inflammatory meds. Sometimes we actually will inject corticosteroids right into the joint. And then in really severe cases, we can use other immunomodifying meds like our biologics or our methotrexate. Acute rheumatic fever is an inflammatory disease that comes about after a kid really, between the ages of 5 and 15 has had a beta hemolytic group A streptococcal pharyngeal infection. It's a mouthful, but what we're talking about is kids who have had scarlet fever or impetigo, a couple different examples of these types of infections. So anyway, the infection clears up. About 2 to 6 weeks later, there is this cross reaction that happens in their body between the antigens, the streptococcal antigens, and the proteins in target organs like the joints, the heart, and skin, nervous system. So the most common symptom that we see is joint pain. That's pretty severe joint pain. Usually it goes away. Typically it's pretty responsive when they take an NSAID. It decreases. But this response also can cause bigger problems like carditis, new murmurs. It can enlarge the heart, and these changes are usually not picked up on until later on in life. So what happens is valves become so damaged that in time they need to be replaced. And then with the skin stuff, some patients develop a rash. So what we do is treat with antibiotics, corticosteroids to keep the swelling down, and then watch for those changes. And this is where we will stop in chapter 52, although I would encourage you to check out gout, which is not in the assigned readings, and I won't test you on that, but it is something that you will come across in practice.